Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is part 3, Diuretics, in the Pharmacology for Nurses Learn Shop. The learning objectives for this Learn Shop are basically just to review some of the renal anatomy, then look at the diuretics, and let's see what you know at the end. Okay, now basically renal function is to excrete waste products such as urea, creatinine and uric acid, and excess water as well, which essentially is plasma water, which is urine. When we look at the gross anatomy, we're looking at the renal pelvis, the renal medulla, the calyces, the renal cortex, and then the extensions, the ureter, which eventually becomes the bladder, the urethra, and exit. We have a renal artery and a renal vein as well, basically the kidney. Now the functional unit of the kidney is the nephron, and the nephron consists of the glomerulus, which allows entrance into the Bowman's capsule from an arteriole from the renal artery and the renal vein. The arteriole goes from the glomerulus. This eventually goes to the proximal tubule, becomes the loop of Henle with a capillary network. Then the distal tubule, it goes to the collecting duct and eventually to the urethra. Now, the renal glomerulus, we're talking about glomerular filtration. And the glomerular filtration rate is approximately 125 mils per minute. And this results from blood inflow to the afferent arteriole, which goes into the Bowman's capsule, is cleansed. The excess goes into the proximal tubule as filtrate. The cleansed goes into the efferent arteriole of the glomerulus. Now the glomerular filtration rate of less than 60 mils per minute results in renal insufficiency. Less than 20 to 30 mils per minute is usually associated with end-stage renal failure. Now the diuretics that we'll be looking at, we're looking at the rationale for administration. Well, the rationale for administration of diuretics basically is to produce urine, which decreases preload or the circulating blood volume, which decreases cardiac workload and improves cardiac performance. So the rationale would be for people who are hypertensive, have heart failure, pleural effusions, or any effusions, anywhere. It could be cardiac as well. Peripheral edema, pericardial effusions, ascites, renal insufficiency, and anasarca, which is a form related to right heart failure. Now, when we look at diuretics, let's look at an overview. Now, the types of diuretics that we'll be reviewing here briefly are loop diuretics, thiazide diuretics, potassium-sparing diuretics, osmotic diuretics, carbonic anhydrase inhibitor diuretics. Now, loop diuretics, the most common one that we know or should know as nurses is Lasix, trade name, furosemide, generic name. And furosemide works on the ascending loop and it inhibits reabsorption of sodium and chloride. It's a loop diuretic. The action is to inhibit sodium, potassium, and chloride reabsorption. It's an antihypertensive and it causes venodilation. The mechanism isn't understood why it does that. So it's good to decrease afterload as well, and more importantly, decrease preload. The adult dose is typically 20 to 80 milligrams over a 24-hour period, but this depends on your organisational policy. The same applies to the paediatrics. The indications are for hypertension and congestive heart failure. Major adverse effects will be metabolic alkalosis because it gets rid of hydrochloric acid or hydrogen ions. It can cause hypokalemia and it can become nephrotoxic. Another loop diuretic is Boumetenide. Trade name Boumex, but there are lots of them. And this is an ascending loop diuretic which inhibits reabsorption of sodium and chloride again within the loop of Henle. The action, similar to furosemide, but it's 40 more times potent than furosemide. And the indications are basically the same: hypertension and congestive heart failure, but it's more nephrotoxic. And it does cause hypokalemia and hypotension. The next group are thiazide diuretics. And if we look at them, we're looking at, probably a common one is hydrochlorothiazide. And this has an effect on the distal convoluted tubule and inhibits co-transporter reabsorption of sodium and chloride. Its action is to inhibit sodium, potassium, chloride being reabsorbed. So therefore it becomes an antihypertensive. Dosage for both adults and pediatrics depends on your organisational policy, but this is one that is generically recommended. Indications are same: hypertension and congestive heart failure, and major adverse effects, as most, are nephrotoxic, hypokalemia and hypotension. Spironolactone is a potassium-sparing diuretic. Pharmacological name, one of them is aldactone. And in the distal tubule, spironolactone spares potassium. So it's now the action of spironolactone or potassium-sparing diuretics is to inhibit potassium excretion. It also has a positive inotropic effect, and it's an antihypertensive. So therefore the indications are for hypertension and congestive heart failure. However, because it's not excreted as effectively, it's spared, it can promote hypokalemia, nausea and vomiting. The typical dose is 25 to 100 milligrams once a day, or BD in divided doses. The most common osmotic hyperosmolar diuretic is mannitol, sometimes referred to as osmotrol. And this works on the proximal tubule and it prevents water reabsorption. When we look at mannitol as a hyperosmotic diuretic, it works in the proximal tubules, as I said, and it keeps more water in the tubules because of its hyperosmolality. There's an increase in osmotic concentration and pressure, and therefore this increases urine production because more water stays in the tubules. The initial dose is 0.5 to 1 gram per kg per dose, and maintenance 0.25 to 0.5 grams per kg per dose over a 6-hour period. The indications are typically for high intracranial pressure and renal failure that's not responsive to other forms of diuretics. Major adverse effect will be hypovolemia. When we look at carbonic anhydrase inhibitor diuretics, the most common one would be acetazolamide, also referred to as Diamox. And it works on the proximal tubule and it retains hydrogen ion and excretes bicarbonate. Its action is as a carbonic anhydrase inhibitor, as I said, excreting bicarbonate in the proximal tubules, retaining hydrogen ion in the proximal tubules. However, the effect is lost over a period of 4 days. The kidney adjusts. The dose depends on your organisational policy, but typically these would be the recommended doses, but you do have to follow your organisational policy. Indications are for hypochloremic metabolic alkalosis and patients with glaucoma. Major adverse effects are hypochloremia, malaise and polyuria. When we look at adrenergic agonists, we should consider dopamine, inotropin, which we looked at as a positive inotrope and agonist in the cardiovascular workshop or learn shop. Now, dopamine is a distal tubule antidiuretic hormone blocker. So if you block antidiuretic hormone, you get a diuresis. It stimulates the dopaminergic alpha-1, beta-1, beta-2 receptors. So therefore beta-1 increases cardiac output, which increases renal perfusion. The dopaminergic increase renal perfusion and the glomerular filtration rate. However, it inhibits antidiuretic hormone in the distal tubules. Infusion typically at a renal dose is about 2 micrograms per kilogram per minute. You wouldn't go up to a maximum dose because this would cause vasoconstriction and affect renal flow. So typically the renal dose is 2 to 5 micrograms per kilogram per minute. And it increases renal perfusion. It's indicated for oliguria with patients that are now with normal volume. They're not hypovolemic. So the major adverse effects can be hypertension, tachycardia, and cardiac dysrhythmias. So let's review. Name the 4 indications for commencing a diuretic. Hypertension, heart failure, pleural effusion, right heart failure with anasarca, ascites, a pericardial infusion, peripheral edema, and renal insufficiency. Name 1 loop diuretic and 1 potential adverse effect. Furosemide or Lasix, hypokalemia. Name 1 potassium-sparing diuretic and 1 potential adverse effect. Spironolactone, which can result in hyperkalemia. Name 1 diuretic that's used to treat metabolic alkalosis and 1 potential adverse effect. Acetazolamide or Diamox, malaise is one of the adverse effects. Name the adrenergic agonist that can be used or administered at a renal dose. That would be dopamine, inotropin. Okay, thanks everybody. That's the end of this Learn Shop. If you're interested in this or you think it's of any benefit, please recommend it to your colleagues. Subscribe if you choose to, and then review part 4 to 8 of Pharmacology for Nurses on YouTube with Dr Manny Learn Shops. Thanks, and see you again.